This lecture is going to be on the physiology of sexual response. So in a nutshell, we're just going to look over male sexual response and then female sexual response. So a couple interesting facts before we get started. Average length of time for coitus lasts around 4 minutes. Most married couples have sex a few times a month, and most people think other people are having more sex than they're having. Over a third of women report low sexual desire, and sexual frequency and desire changes over the lifespan of the person as well as a relationship. So when considering the sexual response for males, the Masters and Johnson model, which was a research team that first started out in the 50s, they're considered to be the primary model when we think about sexual response in men. And oftentimes women are also put under the same model, but we'll talk more about different models for women when we get there. So we can see that it starts with excitement, and then that plateaus, and then orgasm, and then resolution. So we're going to go through each one of those now. So the first image we're going to have in our mind when we think about men is an on and off switch. So as far as the on switch is concerned, we can think about psychogenic components that can lead to excitement. That could be thought, visual stimulation, and the brain can enhance or dampen these responses. But it doesn't take much. It's just an on or off switch. Any of these things could lead to the switch turning on, and then the brain could choose to enhance or dampen it. And then there's reflexogenic or tactile stimulation that can also lead to excitement. So basically we're thinking about fine touch here, and there's actually a reflex to the spinal cord, so erection doesn't even have to get to the brain in order to happen. So basically we can avoid higher corticocenters in the brain in order to get to an erection. So I'm just going to show you here. We have our penis, and then there are mechanoreceptors on the glands, and the pudendal, so it would go from the glands to the pudendal nerve, and then that would come to the sacral plexus here, and then it could go to higher cortical centers all the way up to the brain here, or it could just get to the spinal cord and then come right back to the penis, which would cause an erection. So basically it's dilation of the arterioles then in the erectile tissue on the penis, where even if the spinal cord can't connect fully with the brain, all you really need is that intact autonomic system with a sympathetic and parasympathetic stimulation, and that can lead to an erection. So just something to keep in mind. Okay, so then for male erection, this is our cross section, with this being the dorsal surface and this being the ventral surface of the penis. So we have our corpora spongiosum here and here, and basically that's staying the same. You see that it does engorge with some blood, but this part remains essentially flaccid so that the urethra doesn't get kinked off, and because that's going to be our passage for sperm. Whereas the corpora cavernosa, these two here, they're going to fill with blood, and that's going to make them rigid. And so that's how erection happens. So we'll see here, parasympathetic activity triggers release of nitrous oxide, and then that nitrous oxide will lead to vasodilation and then engorgement of these corpora cavernosa spaces. So we use the same terms to describe both male and female erections. So tumescence is when the genitalia area is filling with blood. So you can see erectile tissue is becoming engorged with blood, and that's the process of forming an erection. Or in women, that's the process of like vasocongestion in her genital area, which we'll get into more in a little bit here. And then erection, that's the penis becoming hard enough to permit sexual intercourse, and that requires an intact autonomic nervous system. And detumescence is basically when the congestion, the vasocongestion resolves. So subsiding of blood from the cavernous spaces. And detumescence will take place faster if orgasm has occurred. Otherwise, that process can be a bit slower. So other forms of male sexual response that are happening during excitement and then into the plateau as well as orgasm. The dartos muscles are pulling the testes up and closer to the body. So again, that's making sure that they're not damaged in the process. That's a protection mechanism. And then the scrotum contracts, thickens, and enlarges in some men. And we have an increase in blood pressure, respirations, and heart rate. That's throughout this process. Increasing tension, and then pre-ejaculatory fluid, which comes from our Cowper's glands, also known as our bulbourethral glands. And that likely doesn't contain sperm, but if sexual activity took place recently, there could be some sperm in the urethra from the last time that they had intercourse. So that's just something to keep in mind. Technically, pre-ejaculatory fluid shouldn't contain sperm, but there is the possibility that there could be some sperm, like residual there from the last time they'd had intercourse. So that's something to keep in mind when you're counseling patients about the withdrawal method. And probably would be playing into even people who are using it perfectly, that would play into the failure rate, which overall it's a pretty good method if you're going to use it perfectly, but that faulty piece there probably comes from the possibility of there still being sperm in the pre-ejaculatory fluid. So distinguishing from emission and ejaculation again. Emission is loading, and then so that would be the time when you would need to withdraw. So that's when the Cowper's glands have released their fluid, but then all the fluid that's actually going to be in the semen is ready to go. So prostate, vas deferens, seminal vesicles, all of them have emptied their sperm and their fluid into the posterior urethra. And then ejaculation is the pelvic floor muscles contracting, and then that causing the expulsion of semen from the urethra, which together is known as orgasm. So resolution is detumescence, or that vasocongestion resolving, and then resolving tension and relaxation. And then for men, there's a refractory period. There isn't for women. So this is after an orgasm. Men cannot physiologically have another orgasm. So you may be able to have another erection, but another orgasm wouldn't be possible. The length of time for this refractory period differs from men to men, and it gets longer with age. And sometimes stimulation of the penis at this time can be uncomfortable. If orgasm doesn't occur, it takes longer for that vasocongestion to resolve, and that vasocongestion can sometimes be considered pain for men, and this is where the term blue balls comes in. Okay, so just a brief overview for men then. Excitement is that psychogenic or reflexogenic erection, and the dartos are drying up the testes to protect them. Scrotal skin is thickening. And then plateau, we have increasing tension, heart rate, respirations, blood pressure, skin flushing. And then orgasm would be the emission of the pre-ejaculatory fluid, and then contraction of pelvic muscles, which would lead to ejaculation. And then resolution would be the resolving tension, and then we have the refractory period for men when another orgasm isn't possible, but sometimes erection can take place sooner than you would be able to have another orgasm. So changes in the aging male, it can take longer to reach and attain orgasm in middle and later life. And then erection takes about 2 to 3 times longer to occur in the 50s than in the 40s. And some of this is going to be related to cardiovascular health too. So promoting just lifestyle factors can make a big difference in people's sex lives in middle and later in life. So let's see, what else do we have here? Okay, so if you lose an erection starting at age 60, it can be a lot harder to regain it. And then direct genital stimulation might be required in order to achieve a full erection, so that psychogenic effect may no longer be enough to achieve an erection. And longer refractory period, and then direct genital stimulation may be required to achieve a full erection, which I guess I already said. Okay, and then Viagra can come into the picture, but I don't think we're going to get into that now, but that can help with a lot of that. Okay, female sexual response. So we had our on and off switch for men, and then women, we're going to say it's a switchboard. So Masters and Johnson's model has been used for women, but Basson, and I'm not sure if I'm pronouncing his name right, but Basson is a more recent model for female sexual response that has been touted as more accurately reflecting how a female sexual response cycle goes. So let's take a look at his model. So it's circular. There's multiple motivators here, and women can also get easily distracted. So let's say she has a motivation for sex. There needs to be a willingness to becoming receptive. And then we see here sexual stimuli with appropriate context. So that appropriate context piece can be a big player. Psychological and biological processing. So spontaneous innate desire plays into that. And then subjective arousal and responsive sexual desire. And then you can have sexual satisfaction with or without orgasm. And that's basically a woman's call as far as is it satisfying or not. But that's certainly appropriate. And then we also have, in addition to potentially orgasm, but either way satisfaction, we have non-sexual rewards here that play a bigger role for women as well, including emotional intimacy, well-being, lack of negative effects from sexual avoidance. And then we come up here, multiple reasons and incentives for instigating or agreeing to sex would then play into motivation, and then that cycle can continue. And at any point here, she can be derailed in terms of her desire to engage in sex, as well as her desire, I guess I'm saying both her motivators for wanting to have sex as well as continuing to have sex once she's in the moment. And I was running out of picture ideas, so you will now see flowers and butterflies because I felt like my slides were looking a little bland. So forgive me, I couldn't think of anything else to do. Okay, so why do women have sex? To express love, for pleasure, because the partner wants to relieve tension. This could be a really long list. But we also just want to keep in mind a woman doesn't need to have a willingness or sexual response in order to have sex. So just to have that in the back of our minds, physiologically, intercourse can take place without a woman ever desiring it or being willing to experience it. And then as we go through these next set of slides looking at female sexual response, keep in mind that basically all of this would apply to same-sex couples as well. Whether you're counseling men or women. So arousal in women, vaginal engorgement. So this is that vasodilation piece with blood filling in the genital area. That does not always correlate with a woman's subjective reports of arousal, but that does play a role in arousal. Arousal has both cognitive and physical manifestations. And then lubrication comes from a few angles. So the Skene's glands and the Bartholin's glands release fluid. And then when there's vasocongestion in the genital areas, having a lot more blood there, some of that plasma can essentially leak out, and that serves to be a lubricating fluid in the vagina. And that's known as transudation, is that just extra fluid in the vagina from having more blood in the area. And then the uterus rises, and it tends to tent in the posterior vagina. And because the uterus is rising, that lengthens the vagina as well. So the distal third of the vagina becomes tighter, and then there's a tenting or kind of a ballooning in the back of her vagina, in the posterior vagina. So that can increase pleasure for the man to have the distal portion be tighter, and then also it's great for once semen is there, you have that balloon in the back that can hold the semen and the sperm, and it makes it harder for it to come out because that distal portion of her vagina is tighter. So helps with both pleasure as well as practically thinking about reproduction. And that transudation piece, I just put a little note here. That concept of the oozing plasma, if you will, from the blood flow in that area, that's the same thing that's happening in your mouth for your mucous membranes and keeping your mouth well lubricated. It's that same process. So female genital innervation, basically two areas here. So we have the hypogastric plexus. Some of this is review from a couple weeks ago. But the hypogastric plexus is what's serving our cervix, upper vagina, urethra, vestibular bulbs, and clitoris. And then the pudendal nerve is S2 through S4 is what that's tracing back to. And then that's our perineum and external genitalia. So other arousal manifestations in women, so like men, increased heart rate, respirations, blood pressure, and then increased breast and areola size, erection of nipples, and then a sexual flush across the body. Some women have flushing, not all women. And then a change in shape, size, and color of the labia majora and minora, but especially the minora. So vasocongestion or erection, when we think about our clitoris, it is kind of a misnomer. This is actually a pretty big organ, but only this is visible externally. And as you look at research, even though all of this was being found on like cadaver dissections, it was basically ignored for a long time because, well, the assumption being that researchers were wanting to think of women as being more feminine and not at all masculine, and seeing this long organ here and knowing that the glans clitoris tends to erect during intercourse was giving people the impression that females were more sexual than initially thought. There's a lot of disagreement in the research about why or why not, but that's some of the thought there. So we have our clitoral glands as well as our clitoral hood here, and then that's the only part that's external. That's usually about 2.5 centimeters, and then 9 centimeters is what we have here. So that's the branching of the crura here. This is the crura, and then this is our vestibular bulbs, and these areas become engorged during stimulation. So the clitoris is not very well placed for sex. It's not naturally stimulated in most positions, so growing and swelling helps with that somewhat in order for it to be stimulated, which aids in continual arousal. And then we refer to this area here as the corpora cavernosa. So this is our branching with our corpora cavernosa, and then down to our crura. So similar terminology that you would hear with the men. And then just so you can kind of get a perspective for where that is. So here's our vestibule, here's our vagina, cervix, uterus, here's our bladder, and then up at the top here we have our clitoris. And then here's the crura branches and the vestibules there, just to give some perspective. Okay, so we're looking at MRI scans here. So this is our vertebrae, and then this here is the vagina, cervix, anteverted uterus. You can see how it's angling forward, almost anteflexed there. So this is at rest. So we have a vagina, it's about this length. And then we can see here that with arousal, the uterus is moving up, which is lengthening the vagina. And then after orgasm, you can see, like by the end of arousal, the vagina is much, much longer, which I think is helpful if you're counseling women, say who are going to be married soon, if they haven't had sex yet, or if you're talking to younger girls that are nervous about sex, just explaining the physiology, whether that's the rugations in the vagina that are able to stretch, or talking about how even what they have right now versus if they were having sex, the vagina becomes much longer in order to accommodate the penis. So orgasm is the rhythmic contractions of the perineal muscles as well as some uterine contractions. and the Skene's glands. At this time, there's a urethral secretion and sexual arousal that might contain a little bit of urine, but then it's also the Skene's glands secreting a secretion as well. So some people have said that this might even be like a possible ejaculation from a woman's standpoint that can occur at orgasm. That doesn't necessarily happen for every woman. I don't know what I was going to put pictures of here. Maybe I was going to put more flowers. We'll just keep going. So ignore pics on that slide. Okay, so types of orgasms. So Freud basically said, you have clitoris, that the clitoris can lead to orgasm as well as the inside of the vagina. And then he stressed a lot more importance on orgasms that came from inside of the vagina, since that would mean that a penis was typically involved. So that was initially Freud's slant, and then Hatcher basically ended up defining them as vulvar orgasms or tenting orgasms, where the clitoris or outside stimulation is taking place as opposed to uterine or A-frame, which basically comes down to G-spot stimulation within the vagina, and that's where ejaculate may be present in the female. And then there can also be blended orgasms, which would be like a combination of both. So many sources report that some orgasms involve the uterus and some do not. So basically the take-home message here is all orgasms are not the same. So there's a lot of variety, I guess, would be one way to put that, or differences from woman to woman. So women do not have a refractory period. Women can have an immediate second, third, fourth, etc. orgasm based on desires, arousal, and stimulation. And we think about that circular response cycle, so it wasn't linear. It can just keep continuing, assuming that the desire is there, arousal is there, stimulation is there, or not. So many women have never had an orgasm. That's also known as anorgasmia. And you'll see different numbers quoted there, but the most common one I've seen in the research is about a quarter of women. This bothers some women and it doesn't bother other women. So we would define it as primary if they've never had an orgasm, and then secondary would be like if a medication was contributing to them not having orgasms. So SSRIs are common ones there, or thinking about just their medical history too can play into that. Neuropathies can play into that. Sometimes COCs, decreasing libido, can end up resulting in not having orgasms as well. So all of that can play a role. And basically, if it doesn't bother a woman, then this is not the end all, and that's fine. And women can lead very satisfying sex lives without needing to have an orgasm. So just briefly touching on hormones, basically women have a lot of hormone cycles throughout the month, as you've been reading about, and there is some research to suggest that that libido is increased during ovulation. And then additional endocrine factors, thinking about hypo and hyperthyroidism, can really have an effect on women's sex lives, as well as hyperprolactinemia, particularly thinking about libido. So stress and arousal. Stress really derails that circular response of her seeking sex and enjoying sex. So when you think about Maslow's hierarchy of needs, sex is towards the top, so it is not necessary for everyday living, so to speak. And then factors affecting physical and cognitive response. Sleep, worrying about disruption or getting caught, whether that be children or whether that be attempting to have sex in public places, that kind of thing. Fear of pregnancy can play a big role in stress impacting somebody's sex life. And then the relationship status, and ultimately what doesn't affect female response. Just on a final note, yes, sex makes babies, but sometimes we need to be more specific, which I think one of our case studies touches on that a bit. But it's penis in vagina sex that leads to babies. And And if people are having a hard time getting pregnant, making sure that you're emphasizing that as well. I mean, it depends. I would do a full assessment first and see what their understanding is. But then also wanting to emphasize that the penis is going all the way up to the cervix. So we're getting the sperm as close to their end result as possible. And then resolution after arousal, that can occur at varying speeds for women, and it may or may not occur quickly after orgasm. So that's the detumescence is our term there. And some vasocongestion may remain, especially if a woman has varicosities, which can be more common in pregnancy. So that can actually be fairly painful too after having sex. So just something to be aware about if a woman is having issues with varicosities and is bringing that up. And I'm referring to vulvar varicosities just to specify that. Okay, so effects of aging in women. So we have changing hormonal levels, and that can affect libido. And then there's a decrease in vaginal transudation, so having that extra lubrication there does go down with age. And the vagina becomes narrower and shorter, and walls become more atrophic, which can lead to potentially more pain with sex and being more important to make sure that she has enough lubrication on board, whether that's her own or whether that's using additional lubrication. And regular sexual activity can help. So the more it's used, the easier it's going to be to keep using it. So basically it's that vaginal rugations that they just don't accordion as well, so it's less stretchy. And one thing that can actually really help there would be to use estrogen replacement. So estrogen creams. Estrogen is basically what's keeping our vagina the way it is. So having less estrogen on board is what's causing that atrophy. So adding in more estrogen makes that vaginal tissue healthier, fluffier, and stretch easier. And we'll get into more of that in women's health. So conclusions, female sexual arousal is more complicated and less researched than male sexual arousal. Doing a complete history and physical exam really is necessary for almost all patients that are complaining of sexual issues. Often, sexual complaints are multifaceted and really should be addressed from a holistic standpoint, whether that be a mom who's got a bunch of kids and has no time and thinking about what impact that's going to have on her sexual life, to a woman who is entering menopause and is reporting issues of pain in sex that wasn't there before, just wanting to be able to come at it from a physiological standpoint as well as psychosocial and emotional standpoints. And then really to just always be aware that this is a really sensitive topic and it can be really hard to disclose that there's an issue. And usually this is the question that you get after you've asked them if they've had any questions throughout your visit. And then when the visit is done, you start to walk out the door and this comes up. So just really being aware that it was hard to bring it up in the first place and making sure that we're fully addressing it, because what we as midwives are wanting is for the women in our care to lead full lives. And this is part of their lives, and if they're bringing this up as an issue, we want to be able to fully address it and come alongside them in a way that is helpful in enriching their lives. Okay, have a good week.